started tonight. Thanks everybody for joining, and it's great to see everybody. Hey Gus, thanks for just
Hey,
joining.
how you doing?
And so we're really lucky to have a speaker tonight who has a ton of I'd say personal experience on the bike, but also probably personal experience helping many of us get back on a bike. Dr. T is a local orthopedist and also a triathlete as well as a cyclist. He rode with us in our last Italy trip and as just an all-around good guy. And my wife cornered him over the weekend when we were enjoying some of his good wine together and talking about cycling and all of this stuff. And he, Dr. T, you agreed way too easy.
Yeah.
Your term should have been much higher.
I'm a pushover for women, I say.
But without further ado, we thought we'd open the floor up to Dr. T and tell us a little bit about his practice and maybe some preventative medicine.
Sounds good. All right. So I've been in practice 20 years in Thousand Oaks. I pretty much do a general orthopedic practice, but I have specialty training in knee surgery, a lot of knee replacements and arthroscopic knee surgery, and fracture work. So it's kind of a general practice, but I do have special fellowship training, which is kind of beyond your standard 5 years after medical school training in the knee. And I spent in New York. About when I'm 53, so when I turned 40, I started getting into cycling through just trying to get fit. And my type A personality led me to Ironman. So that's how I got into cycling. And then I met a bunch of people along the way, including Scott. And so I met Soren through, unfortunately, a bike crash. I put him back together, and so I met him. And then he kind of pulled me into more of like the cycling, and got one of the fancy Italian bikes and did the Italy thing in 2019. It was freaking awesome. So kind of hooked on that. It's just, I liked it because, you can kind of enjoy the beauty of Italy and the cycling, and then you can always go for a wine and dinner afterwards. So it was a good combination. So I got asked to speak about preventative injuries for cycling. Like I said, I'm an orthopedic surgeon. If I was a dermatologist, I'd tell you, stay away from the asphalt because you get a rash if you touch that. So I'll just talk about what I know, which is orthopedics. So I'm going to talk about lower extremity injuries that are common to cycling. A lot of it has to do with bike fit and technique. A lot of it, because obviously it's repetitive what we do, and optimal seat height, where the position of the seat is forward and back, a handlebar position, which will open or close up your hip angle, the length of your crank. The longer the crank arm, then you're going to have better mechanical advantage for your pedal stroke, but it puts more force on your hips and your knees. And then the foot position on the pedal. So the fit of the bike is going to lead sometimes to some of these issues that people can have. And then the technique, usually a low cadence puts with a higher force, puts a lot more strain on your limbs. And sometimes, if you don't have good gear selection, that can lead to having to use a more difficult gear and put more strain on your lower extremity. So starting off with the knee, because the knee is the most common complaint that people have. And generally, I'm an advocate of cycling for just people who have knee problems. I think it's probably the best exercise, and I often advocate cycling for people who have knee issues. But mostly, I tell people, we all know the measurement of watts, and watts is the product or the multiplication of your RPM times your resistance. So you can get to the same watts with a higher cadence. And so I'm always telling people to have a higher cadence and an easier gear, like somewhere in the 85 category. But one of the things that we see with people with the cycle is something we call patellofemoral syndrome. So patellofemoral syndrome is where how the kneecap tracks over your femur. And it would lead, like, people have what we call anterior knee pain, like pain in front of your knee. You see that when you have a lower cadence and like climbing a hill, pushing a harder gear. If your seat's too far forward or too low, it's also going to put more pressure on your kneecap. And there's an angle we call the Q angle, which is a quadriceps angle, which is the alignment from your hip to your foot through your knee. And sometimes that makes a knock, that Q angle or quadriceps angle. If somebody has, for example, like a pronated foot, or if they just have the way their anatomy is, they're more knock-kneed, they have a steeper Q angle, and that steeper Q angle puts more pressure underneath your kneecap. So the patellofemoral syndrome is anterior knee pain. You see it with lower gears, with a higher resistance, and generally we recommend, everything kind of always starts with make sure you have a good bike fit. If you do have like foot issues, pronation or flat foot, sometimes you have to have an insert or a wedge on your cleat in order to help that alignment. You can do quad strengthening, the VMO, the vastus medialis obliquus, which is that inside muscle. Often cyclists have a pretty good VMO muscle, but that muscle often will help better kneecap tracking. So doing like straight leg raises with your knee turned in or your foot turned in will help build your VMO. And then stretching of your calf muscles and your hamstring muscles would be important to help balance. And so a lot of times we see people who have knee issues with cycling, and it's not that their legs are weak. Obviously cyclists have good strong legs, but it's more about their muscles in their legs are imbalanced, meaning there is the quadriceps, which is the front muscles, and then the hamstrings and the glutes, the posterior chain. And so when there's an imbalance between those two muscle groups, then you have abnormal forces around the knee. So it's not that people are weak, it's just the muscles are imbalanced. They're too powered on their quad and not their glute or their hamstring. So those kind of strengthening exercises for your posterior chain is also something that should be addressed in some of a strength training program. So patellofemoral syndrome is this anterior knee pain. Then there's a couple tendinitises that cyclists can get. There's patellar tendinitis and quadriceps tendinitis. So the knee has the quadriceps muscle, and then there's the patella. So where the quad attaches to patella is the quad tendon. And then the patella attaches to the tibia through the patellar tendon, where you tap on the knee and the knee kicks forward. The upper one is the quad tendon, the lower one is the patellar tendon. So people who cycle can get tendinitises of those areas, and that would be, you would notice that if you pushed on your knee and right where your muscle attaches to your kneecap on the top, that'd be your quad, and you'd have tenderness there. Or if it was below, it would be where your patellar tendon is, and those areas would cause tendinitises. Again, those angular positions that people have, again, some of it is just anatomic, the way your body's designed, and some of it could be from bike position. If the saddle position is too high or too low, you're going to have extra pressures on those areas. So again, addressing any seat issues, addressing any foot hyperpronation issues, because when your foot pronates outward, it puts this angle on your knee. So sometimes if people's foot is like that, you need to be corrected more neutral. That's either going to come from a wedge underneath your cleat or something that's going to go like an insert into your shoe. So that would be how you address that. Sometimes people have another condition in their knees called a plica syndrome. Plica syndrome will be a snapping in your knee. Every time you pedal, you hear a click, a click, a click, a click. And that is, the knee has a plica. And a plica, what that is, it's like a remnant from embryology. Like when we were like, generations ago or whatever, eons ago, our knee had two compartments, and there was this membrane that separated the knee. And it's recessed over time, but in 30% of the people, there's a little shelf left over in the knee. And because of the repetitive nature of cycling, sometimes people can get thickening of that plica, and you start to have, it could cause pain if it gets inflamed. And every time you pedal, you hear a click, 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 and there's this thickened plica. So that also would be, we see that when people have alignment issues, again, with their knee and their foot. It could also be with a higher resistance, pedaling, in a harder gear. That one is usually treated with rest, and there is arthroscopic procedures we do in those cases. It's somewhat of a rare condition, but sometimes people do in fact have that. There's also a bursitis that you can get. The hamstring tendons, they come around to the front of your knee on the inside. Excuse me. and can create a tendonitis. And that's kind of on the shin, the upper part of your shin, where you would have like a pain right there. And that's from friction of the hamstring from the repetitive nature clicking over the front of your shin bone. That causes what's called pes anserinus bursitis. Like it's these three tendons that attach. If somebody's had somebody's had ACL reconstruction and they've had their hamstring tendons used for their ACL reconstruction, that's that pes, those three tendons. And sometimes that can create friction on the front of the knee. So that's below the knee to the medial side to the inside, tenderness right there. And that's usually, again, from muscle imbalances, having too strong of a quad and a weaker hamstring. But that would be pain kind of in the front of the knee. All the other kind of knee stuff that you hear people get, like meniscus tears, ACL tears, things like that, those are not really kind of things that cyclists are really going to get unless there's some kind of an injury or something like a fall or some kind of a blowout. But those are usually like court sports, field sports, things like that. People tear meniscus and cartilage. So most of the knee stuff that we see with cycling is just, it can be fixed with either bike fit or stretching of the posterior chain and strengthening of the posterior chain. Moving on to the hip stuff we see is IT band syndrome. The IT band comes down to the outside of the knee and attaches to the outside lateral half. And as it goes to where it attaches on the tibia, it sends fibers up into the patella. And when those fibers go up in the patella, it can track sometimes patella to the lateral side. So it creates some tracking issue. And also it rubs on the outside of your knee. So that was like a lateral outside knee pain, sharp stabbing to the outside of your knee. And that's just from the repetitive nature of bending your hip and your knee when you cycle. And usually it rubs right around 30 degrees. So if you have a high seat height for whatever reason, that puts more tension on your IT band and that can cause friction in there. And again, foot position can also affect that. So when people have IT band syndromes, usually want to lower the seat, have a forward position on your seat, and you can open if you raise your handlebars, you can open up your hip angle, and that would take some pressure off of your IT band. So that's the IT band when it reaches the knee, but you can also get irritation to the lateral hip, to the outside of your hip. So if you reach down like kind of on the seam of your pants where your pocket would be, and that prominence of your bone is your trochanter, which is the side of the hip. And then people can get a bursitis to the outside of that trochanter, and that's like lateral hip pain. That's from, again, the IT band rubbing over that part of your bone. Sometimes people can have like a back issue, and that can sometimes irritate that. So that's usually lateral hip pain right to the outside. That's like foam rolling out your IT band, glute strengthening exercises. Those are kind of the things that people do for trochanteric bursitis. Injections are helpful in a lot of these bursitis, tendonitis conditions. They can provide therapeutic, value. They can give you some relief. They also are diagnostic, so sometimes when you have these conditions, you have to make sure that we have the right diagnosis. So by doing a cortisone shot, at least temporarily, you can get some pain relief, which would validate the diagnosis, and then you can formulate a treatment plan. The other thing people can get in the hip who cycle is the hip flexor tendonitis, the iliopsoas tendon, and that's in the groin. So that's a hip flexor attaches right on the upper part of your femur bone. So you would have groin pain with that one. And that would also be associated with people who have low back pain. If you have a stiff back and your pelvis doesn't rotate properly, there's a lot of pressure on your hip flexor. That also can come from the seat being too high. So depending on, the source of the problem, you either want to do some core strengthening to help with the back and look at that seat position. The next part is moving down the leg, down into the tibia. What we see sometimes in the tibia is like a shin splint. The technical term is a medial tibial stress syndrome. That's where the muscles attach on the inside of the shin bone. The muscles attach to the bones through a lining called the periosteum. The periosteum, peri means around, osteum is bone. So the lining around the bone, the muscles attach onto that. So people sometimes have calf pain along the bone, like you touch the bone and it's like really tender. That is from like a shin splint. And typically you see that when there's a sudden increase in your training regimen, like all of a sudden your volume goes up for whatever reason. That can lead to that. Also, back to the foot, if you have hyperpronation of your foot, And what's the muscles they pull and they put more pressure on the inside of that bone, and that can cause this shin splint syndrome type thing. So usually this one is going to be modifying the volume, looking at cleat and foot position. Again, wedges and orthotics sometimes play a role here. There are some cases where people can get stress fractures in the tibia, and sometimes that has to do with cyclists. You know, if there's some kind of potential nutritional deficiency or metabolic condition, like your body doesn't process calcium. You know, it is a non-weight bearing sport, obviously, so that does create some osteoporosis depending on each individual. There's different bone densities, but stress fractures do occur. I mean, it's kind of a spectrum. So like the bone has the ability to take a load, but when it's repetitive, it does start to create stress reaction, just like a coat hanger or paper clip. If you bend that enough times, you know, it obviously heats up before it breaks into two. As it's heating, the material's changing. So that's kind of like a stress response to the bone. So repetitive nature of cycling and you're having a load, say there's some osteoporosis or penia, which is like a low bone density, maybe either from lack of resistance exercise or maybe something hormonal, or maybe something nutritional. That repetitive load can potentially create stress reactions to bones. And usually it's the tibia bone, the long shin bone. It's usually, again, seen when all of a sudden the increase of the volume goes up. Both this stress response or stress fracture and the shin splint diagnosis would be made with an MRI. So if you had shin pain or leg pain, it would either be shin splints or stress fracture or stress reaction. You'd rule that out with an MRI. Most of those cases are just rest and they'll resolve. If it is a stress response or stress fracture, you just want to make sure you metabolically get checked, that you're processing calcium and vitamin D properly. Sometimes you have a very low, and this is kind of more for women, if you have like a low body fat, the body fat is what converts your estrogen to the active form, and that's what absorbs the vitamins in, the vitamin D in. So you could have all the vitamin D you want, but if you have a super low body fat as a woman and it doesn't convert to its active form, it won't absorb the vitamin D in your system, so you'll actually be osteopenic or osteoporotic. So we see that a lot in like gymnasts and dancers that are super lean, tight, and they're super fit, but they're super low body fat and they don't process the hormones properly, and that does happen. So it's something that anytime I see a stress response in a young person, especially female, I have them check with their gynecologist on their hormones and then their nutritional stuff. The other thing that happens in the lower extremity is something called a compartment syndrome. Compartment syndrome can occur either by a trauma or by exertion. So like Tiger Woods, he had compartment releases because his leg was crushed in that car accident. I mean, I don't know the details of it, but when he was crushed, the muscles swell and the lining of the muscles have like something called a fascia. Think of it like a sausage lining. The sausage lining, it's thick in this instance, and then there's a muscle inside that lining. So if you have trauma like crush and that muscle swells, that fascia doesn't allow it to expand. Just like if you've got swelling in your brain, your skull won't let it expand. And it can put pressure on the muscles, and then the blood doesn't get through the muscle and the muscle can die. So somebody who has like a trauma like Tiger Woods, they do a fascial release. They open the fascia to relieve the pressure off the muscles. And then at a later point, they go back and close everything back up. But athletes can also get exertional compartment syndrome. And what that is like you got strong legs, strong muscles, but that fascia has a defined space. It only grows is only so big. So as the muscles start to engorge with blood and swelling as you work out, that fascia doesn't allow it to expand. And when that happens, basically the blood flow will decrease to the muscle, and you start to get like cramping and numbing, and it usually starts like maybe 10 minutes into a ride or to some kind of exercise. It could happen in running too, and then it stops when you stop running. So that's because the muscles engorge with blood, and it just doesn't, the blood doesn't go through the compartment. So that's just the diagnosis that has to be made by a clinician. And there's a measurement. We would put a needle in that muscle and measure the compartment after exercise to see what it is. And if that exceeds a certain amount, that the blood's not getting through, and that makes the diagnosis. And then there's like a surgical release of that fascia. It's not that common in cycling. I see it in runners though a lot. And so it's called exertional compartment syndrome, and that's in contrast to like trauma. And the last part's the foot. I mean, the foot's is a pretty common area where cyclists have some issues. The Achilles tendon is one of the main ones, and that's from the repetitive nature of the cycling. And if you're improperly fit and the bike is too low, and every time you push your heel really like drives the heel down deep like that, all that tension is going on your Achilles tendon right where it attaches onto your heel bone, the calcaneus, and that can create a lot of repetitive irritation and tendonitis on the Achilles. Also, if you have an improper pedaling technique, I'm sure everybody's seen, somebody climbing somewhere where they're mashing down with their heel. That puts a tremendous load on the Achilles tendon and creates a lot of pressure there and causes the tendonitis. Or if your cleat is too far forward and you have a big lever from your cleat to your Achilles, that lever arm is increasing and putting that pressure on your Achilles tendon, and that could also create the tendonitis. And so that's just basically proper foot alignment and bike fitting, and then stretching your calf muscle if you do in fact have an Achilles tendonitis. Cyclists also get a plantar fasciitis, which is the bottom of the foot. That diagnosis is made when your description is like the first step out of bed hurts, like your first step, you get out of bed in the morning after sleeping 8 hours and you step, it hurts underneath your foot, or after prolonged rest. That is also because those people have limited ankle movement. And so raising the seat on that individual would help, as well as using some night splints. If you have a plantar fasciitis condition, usually a splint at night, you can buy them on Amazon. You put them on, it keeps your foot like an L and stretches your calf. Calf stretches also help for plantar fasciitis. And then sometimes we inject people with cortisone if they come in with that. Foot numbness, not uncommon. That's usually just shoes being too tight or too narrow, or if the straps are too tight. There's some nerves that are just under the skin on top of the foot, and they can get squeezed by the straps, or as we exercise, run or cycle, the foot swells, and that can cause increased pressure as well. And that's usually just shoe modification and stuff. And then the final condition that we see in the foot is pain underneath the ball of the foot right here. We call it metatarsalgia, just pain under the second, usually on the second or third toe right there. And that is just because of repetitive load across the ball of the foot. I know with all those carbon fiber soled shoes that we use, that stiffness is good for energy transfer, but it puts a lot of pressure underneath your foot. So that could cause pain right on that ball of your foot. If you do have that condition, or you have to suffer from that, you can look at either getting a different shoe with a less rigid sole to it. There are also pads you can put in the shoe, something called a metatarsal pad, or an insert on your shoe to take some pressure, relieve that point underneath your foot. And then the cadence. If you're using a lot of force with your low cadence and a high resistance and a high pressure, that can also put that abnormal force on your metatarsal, causing that pain. So I kind of went through the lower extremity stuff. I'd be happy to answer questions on anything, or if somebody's got an ailment, I can try to Zoom diagnose it. It's kind of what I've been doing anyways for the last year with COVID.
Wow, that was pretty thorough, Dr. T.
Yeah, I know it was a lot of information, but
that was impressive. That's like a 2-day bike fit class right there.
is it?
Yeah.
I know I hammered through a lot of them, but yeah, I mean, we were talking about it over the weekend. You were mentioning that the quad tendon, patella tendon is something you see a lot, right, Scott?
Yeah, so I mean that's probably the number one thing that I see when we get into bike fit, and it's generally because the saddle height is often too low for a new rider, and that's also generally because people are uncomfortable getting off the seat when they come to a stop, and so the seat is just too low. Um, the other piece that's highly connected to this is just overall posture and, you know, hinging at the hip and not rolling the back over like making a kind of a rounded back, but trying to have a straight back and hinging at the hip like you would if you were doing a squat.
Right.
And that helps activate that posterior muscular chain. You know, when Dr. T and I started to spend real time together, we looked at, you know, we were looking at your bike fit and setting
Yep.
it up, and you know, really unlocked a lot of power and bike handling by having the weight, you know, distributed on the bike properly. And you know, for any club member, I mean, if you're not feeling good on the bike, you guys you guys know, but it's worth repeating. I'm happy to look at your bike fit anytime. And but if you have some kind of chronic pain or you're curious, I mean, here's a great opportunity to ask the doctor, literally. He knows.
Ask the doctor. Doctor's in.
Yes.
Yeah, the
You
back,
know, Scott,
the core is key. You know, I think that was one good thing with at least triathlon, is that, you know, with the swimming, there was the core part that was always being engaged. And so I think that I've been fortunate. I haven't had too many personal injuries, like, you know, repetitive use injuries, like these kinds of things, right? I think I attribute it to the fact that you're cross training, and then there's some strength training and core strengthening with the swimming part. So I think, yeah, for sure, core strengthening and that posterior chain stuff is really important. All that glute, like
Yeah.
examples would be like planks. You know, you're the forward plank, side plank, Russian ball twist, like Russian ball exercises. Like you have, I'm not Russian ball, the Swiss ball, the big Swiss ball. You know,
Yep.
you're on the ball with like the ball's here, and then your heels are there, and you tuck the ball toward your butt and you push it away. Tuck your ball and then push it away. And then reverse bridges, where you're kind of like your head, your butt, your knees, your feet, and you drop your butt and you lift it up and you squeeze your butt cheek. And that's the posterior chain exercises. There are simple things you can just do on the floor in a, you know, in your garage. You know, you don't need anything other than a mat and maybe a Swiss ball. But that posterior chain exercise is really, really important.
Yeah. And that is like the key to making power. Those are great exercises. And then another thing you guys have probably heard me say over the years, but if you Google foundation training and go to that website and then go to YouTube and just type in foundation training, there's a 15-minute regiment that if you do it 3 times a week, it just makes a world of difference. And it's sort of like a combination between Pilates or plyometrics and yoga. It was actually developed for Lance Armstrong about 20 years ago. So it started off as cycling specific. And I got to tell you, the first time I went to Italy, by the third day, I'd never had back pain, and by the third day, I was so lit up. I had to KT tape myself, and because it's just so steep and so like continuous. And that's when I got pretty serious about the core, and somebody turned me on to foundation training, and it's been incredible ever since. So I tell everybody I know about this website.
Who developed that? Is that like a PT or an MD or what is that?
Yeah, it was both actually, and they're based in Santa Barbara.
Okay.
Yeah, it's an incredible routine, and you know, it starts off as like a 15-minute routine. You can go to more advanced levels, but just the 15-minute routine, I mean, it's your body, after you do it for a week or two, your body like just starts responding to it in an incredible way. And I use it even like as a pre-race sort of routine just to get my posterior muscles sort of triggering.
Okay.
Yeah,
What is
right. There's the book. Steve's holding up the book.
Oh, it's a book too?
Yeah, it started off as a book, you know, but now it's all online. You don't even need to buy the book.
Yeah. That's how my kids work out. They have like little apps on the phone, and it's kind of like
Yeah.
Peloton. They all just everybody does everything now.
Yeah,
That's
yeah.
cool. They maybe have something like that.
Hey, Brooke, you had a question.
I was going to say that, of course, I don't know if everyone realizes I've been lifting weights year round for the last 10 years. So
Yeah.
every time he says something about, strengthening the posterior chain, your muscles are in balance, I'm like nodding my head up and
Wow.
down over and over again repeatedly. Because a lot of us are cyclists. And if that's all you do is cycling, you're going to have tight hips. You're going to have sort of problems overall. And over the long term, you're going to have that osteoporosis type feeling from the lack of the weight bearing work and leaching your muscles through long bouts of endurance exercise.
Yeah.
So I'm loving hearing everything the doc is saying. But what the other issue about this was he didn't get into, which is not necessarily his bag, is that there are people that have other upper body issues, pain in their shoulders, pain in the hands. And again, lots of those things are corrected by position, bike fit, and first and foremost. And two people that have the exact same musculature, exact same muscles and bone lengths and everything, maybe your seat's in the exact same position to get you the proper fit, and so forth. But how you position your upper body is something completely different that may be different depending upon your flexibility, your riding style, and all kinds of other things. But the upper body positioning is a whole nother aspect of this that wasn't gone into. And I'm not saying it was supposed to have gone into, but
Part two. That's part two.
yeah, exactly. But but then it's it's a whole nother thing with certain musculature imbalances and other things and certain strengthening exercises that can help. Obviously, a lot of people have issues with their hands, and maybe it's just a matter of positioning their hands differently and not bending them so much backwards where they're bending their wrists back but having them straighter. All kinds of different things associated with the upper body that weren't gone into here. But again, if you're experiencing those issues, bike fit, talk to Scott and so forth, first of all. And also there are all kinds of different strength training things that you could do also to help the musculature for those sorts of things. See, I do a lot of long-term endurance events, 500-mile events, multi-day things where, how your bike's set up for doing 5-6 hour ride or a century or something's one thing, but when you're riding for 12 hours and 24 hours, that puts more strain on all kinds of things that you're not used to experiencing.
Yeah.
And that's where I feel like doing the strength training work helps me out and allows me to not be sagging in the upper body and then putting more pressure on my quads as I'm riding and so forth after you've been out for 30, 40 hours or something like that. So but again, if you're experiencing issues with the hands and the shoulders and other things like that, you should see Scott about a bike fit. But also maybe is strength training things you need to do. And it's funny that you mentioned doing planks, and planks are great exercises because they work the core, but it's also a pushing exercise. But I always remind everyone that when you're riding uphill and you're doing a lot of work like sprinting and things like that, you are pulling on those handlebars, and pulling motions use the muscles in the back. And a lot of us that do push-ups and do planks and things, we are strengthening our core and we are strengthening the muscles in the front, the pushing muscles. But you need to also do things like pull-ups and rows and exercises like that, anything with a TRX band, where TRX works because you're using your core muscles and you're using the muscles in the back of your body, the traps and so forth. So those sorts of pulling motion also helps when you're climbing and going uphill, because that's when you're really yanking on the handlebars and pulling back also. Just some thoughts. Anyway, sorry I talked so long.
That's good. No, those are good. Those are all good points.
Yeah, that's really good points. And to Brooks' point, he's been doing this for a decade. He's been lifting for a long time.
Yeah. Awesome.
Yeah.
Some of that hand stuff too, when your core is weak and you're just more on your hands, because you can't, you have too much pressure pushing right on your carpal area, which is right there. That's when if you get numbness in these three fingers, that's a carpal tunnel syndrome. And that is if you're right on the handlebars, right on this part of your palm. And if you're getting fatigued or tend to have a weaker core, and you're leaning on your hands, you're going to put more pressure right on your median nerve, and that's going to create carpal tunnel syndrome. So that's going to lead to numbness in these three fingers. So, but that's bike fit can also adjust. I think I was personally having some of those issues, and on my new bike, Scott Fit for me, we adjusted the hoods a bit and improved my technique. That helped too, but definitely bike fit.
I'll tell you a funny story. I have numbness in my left hand very frequently, and sometimes it's right away on a ride, and sometimes it's long into the ride. And I found out that I'm crimping up my shoulder like this. I'm exaggerating, in this picture. But I'm crimping up my shoulder. If I just relax and drop the shoulder down, then the pain goes away within 5 minutes. And I have to remind myself not to why am I so tense, and loosen up, relax.
Yeah. That's good advice. Everybody else is just perfectly happy on the bike. No questions for Dr. T.
Oh, Gus.
Gus, you're on mute, buddy.
There's John Davis. Just shut
Yes.
up.
Hey, Doctor, what are your thoughts about Q rings? And also, if you have Q rings in one bike and not in other bikes, so you switch from back and forth.
Now, I had Q rings on my tri bike when I was doing the Ironmans, and I didn't have it on my road bike. I personally didn't find it to be that much different. Personally, I didn't necessarily. I understand the theory, but I think it doesn't. To me, didn't make sense for me. I don't really have much anything scientific to say about it as far as if one has an advantage to the other. I think it has to be an individual case. That's maybe more of a Scott. Maybe Scott can make a comment on that, what he thinks. But go ahead, Scott.
I would say on paper, it's a brilliant idea. Creating sort of a smaller diameter circle where your pedal stroke is the weakest, and the largest diameter circle where your pedal stroke is the strongest. It just doesn't seem to work in practice. And I'd say the biggest disadvantage of it is the loss of performance in shifting the front derailleur. Often chains drop anyway, and the Q rings just make it even tougher. And in a race scenario, that's kind of the last thing you want to be worrying about.
Yeah, and I was talking more about the pressure on the knees and the muscle memories and using one another. I built since I built my S5, I built it with the Q rings.
Yeah,
but
what do you
my
think,
other
Gus?
bikes are regular, and there was sometimes that I had a little bit of knee pain, and I didn't know if it was related because of going back and forth. As far as I was happy with as far as the performance with the Q rings. It just I didn't if it creates some type of knee problems by going back and forth one to the other.
I guess you can see how, I guess you can make a theory that if your body's getting used to doing one kind of, cycling rotation on a certain kind of ring, like a Q ring, and then you transition back. You're definitely going to have more pressure. When we talked about those different pressures over your kneecap, think of it just like if you increase the lever arm on your crank, it's the same thing. You're putting more, it's more efficient, but it's more strain on your joint. Same thing. So that Q, you're going to have a longer lever on that point. So you have your higher contact pressure on your knee at that point. So you're going to have more knee pain at that. And then it's going to relieve, when you're on the oblong part. But the increased mechanical advantage translates to more force on your joint. So,
okay.
it's that's probably why I was assuming you're feeling that, but and again, I think it's more muscle imbalance. You're pushing with the quad, but the hamstring is not being utilized enough. And so you would have a muscle imbalance. And that's where I think a lot of this stuff comes from, not just weakness, just imbalance.
Yeah, and going on the point of the gears, yes, it is a little bit harder to switch from big to small chainring, and because of the same reasons, a lot of times.
Gus, you don't use the small chain ring.
Well, and I don't use them much, but sometimes I just didn't switch. Also, being on the Q rings just because of the risk of the chain falling off. When I was on the Q ring, I switched it even less. Yeah. Thank you.
Hand up.
Yeah.
Sue, do you have your hand up? You got to unmute if you want to ask a question. You're on mute, honey.
She moved around. Upper left. Yeah.
You're still on mute, Sue. There you go.
I have arthritis in my knees, in my right knee in particular. And it doesn't hurt when I ride, but it hurts most of the rest of the time, like if I'm sitting for a long time or anything. And I wish there was something I could do about it. Does anybody else have that issue, or does arthritis aggravate other issues with riding, like with tendonitis or whatever other injuries can happen to the knees when riding?
I guess it depends on the severity level. I mean, arthritis comes in obviously kind of, keeping it simple, like mild, moderate, severe, and it really has to do with how much space is in between the joints.
Okay.
If you
I was
have
just curious.
if you have arthritis in one part of your body, you know, usually affects the major working parts like the knees, the back, the hands, the feet. So I mean, it can affect other things because it affects globally through your body.
Right.
This is probably where, you know, the cadence and the gears become very important, you know, because if you're pushing hard, you're putting a lot more force across the joint, and it could technically put more pressure around your arthritic knee, and it can cause pain. It's not harmful. I mean, I tell people this all the time, you know, you're not making damage, because pain doesn't mean damage in a lot of these cases. You just have to be able to try to work through it. So
Yeah, you told me to keep riding my bike, so I keep riding my bike.
yeah. But you know, when you have a knee arthritis, there's three compartments to the knee: the inside, the medial, the outside, and the lateral, and then the patellofemoral compartment. So it depends on where the arthritis is. Majority of people get arthritis in the medial side. So if you looked at the knee would be kind of bowed because you wear down the cartilage, and that affects, you know, where the forces are going across your knee. So those are, if you do have alignment issues, there's again where bike fits come in play, where your foot is, if the cleat needs to be adjusted, or if there needs to be a wedge. So, but if you're not having any knee pain and you just have arthritis, then I wouldn't change it.
No, I'm just riding my bike. Thank you.
That. That's good.
Hey, Dr. T, I got a question.
Yeah, sure.
Yeah, lots of good information. Thank you. You're very knowledgeable. And before or somehow Scott could get us your information to maybe come visit you and make an appointment. I'm sure that's
anytime.
That's my first question. And really short, I've had both ACL reconstruction. Yeah. And briefly, real simple is, do you recommend any good stretching and also good exercising for you know, just building and strengthening besides riding?
Yeah, a lot of the stuff you were talking about with the glute and the core, because you've had ACL reconstruction because you had some injuries, right? Some kind of sporting injury or skiing injury or something?
Yeah, one was motorcycle dirt bikes and the other one was soccer. So it's over the years of separate injuries, but both ACLs on both knees.
Like how long ago?
One was 2006 and the other one was 2016. So they were separate, but I'm fine. I do every activity possible, long distance rider. But I just, you know, I do the typical stretch the knee to the butt, and that's about the only thing I do. And then, of course, do exercises, you know, the typical exercise, you know, gym and at home. But I was just looking for a quick snapshot.
Yeah, like a lot of it is like a lot of stuff that I think is where all this stuff comes from is right at the core, the glute and the core. Because if you have good stability, say not on the bike, but say like you're doing some kind of activity, you're hiking or you're running or whatever, and you have good core stability, your pelvis doesn't dip. If you have weakness in your glutes, your pelvis will dip, and that kind of throws you off balance. And all those off balance things is what can create injuries. So core strength, obviously we all have good endurance, and that's another part of it. So, you know, you always hear about somebody blowing their knee out in the last run of the day, or kind of when their guard is down or when their muscles are fatigued. And that also is an issue. So obviously it's not really an endurance thing with most cyclists and endurance athletes, but the fact is, if you're just cycling and not doing core exercise, a lot of the things that I tell people, bands that use those little bands, you know, like the ones that look like rubber bands, but they're big. You put them just around your knee and lateral sidestep across the room, you know, forward. Okay. You can, or you can put the band, hold it wide, and keep it at your shoulder width, and do squats, you know, and that will engage your adductors, the muscle, this muscle right there, the outside muscle. and that will help keep your pelvis stable. And that pelvis stability, that core stability allows you to be balanced. That off balance is where you could have like injuries from everything down, like knees and ankles and stuff.
Yeah, I'd love to come visit you and talk more individually.
Yeah, no worries, man.
Yeah.
We're on a ride or something.
Oh, anytime. Yeah, but we'll get the information where you're at.
Yes, sir. John Davis.
Yes. Hey guys, how you doing?
What's going on, man? I haven't seen you for a
Not
while.
much. No. Yeah. Hey, I just have a testimonial for Dr. T. It's actually 2 years ago, March, that I broke my ankle in 2 places, and I can't tell you how comforting it was to have somebody that you could call and talk to, and you know, because it's such an unknown for most people on, when you break something, on like, how bad is it? What can I do? What can I do after? And, Dr. T did a great job on telling me what happened, pre-framing and setting expectations of what I can do. And this is only 3 or 4 months before I was supposed to go to Italy in 2019. So, I mean, it's been amazing, the healing, it wasn't easy, but I put in a lot of work, and you told me, what I could do, what I couldn't do. But I mean, if anybody has any questions, Dr. T speaks our language, and he's a cyclist himself. And so if you have any reservations or, anything like that, I can tell you that my experience with Dr. T has been like A+.
Yeah.
Thanks, man. You don't have to break anything to come see me either.
Thank you for that. Yeah, I don't want to go there.
Yeah, you did awesome. You did awesome rehab, man. We got it done. Got to Italy 4 months after. Made me look good.
Yeah, exactly. And that was the other comforting, that you're like, well, I'm going on the trip too. So I'm like, oh, okay, that made me feel better to have, my doctor actually traveling with me.
That was fun. And the next time when Scott and you were both there at the same time, on one of those visits.
So I could have the same testimony, crashed hard. I didn't want John to get all the credit, hurting himself. And so decided to break my pelvis, and Dr. T was definitely the first person we called. And after I got out of the whatever you would call that place, we went and saw Dr. T, and it was just nice to know, somebody who's a cyclist could look after me. I think Jen's probably got a similar testimony. I mean, how many people on this call? Gosh,
Yeah.
it's scary.
I was going to say 100%. And for me, when Dr. T fixed my collarbone after the mountain bike race crash, part of the comfort was knowing that
The grass snake. That's
grass snake. Yes, thank you, Scott. But knowing that this was somebody who was a competitive athlete, who understood what training was, who understood how important that component was as a part of my life. I think I walked in after surgery, that first post-op appointment, and one of his first questions was, "So how long have you been back on the trainer?"
Yeah, right.
I mean, and that was like the first thing. So just having somebody that understands the mentality of an athlete is 100% in your favor to a good recovery, a fast recovery, and a recovery that's going to get you back to your activities that you want to be involved in. So awesome. Yeah,
most of the stuff is all fixable by bike fit, technique, some little tweaks here and there. It's not, most of the stuff I talked about, at least, there's obviously the crashes that some of us getting ourselves involved with, but I mean, a lot of the stuff that you have little pains in here and there, they can be fixed without surgery, without other, just, it's got to hear you out and figure out what the problem is, and we'll get it fixed. So
you just need to have the best orthopedic surgeon in the LA area and be happy.
Appreciate that. I appreciate that. Thank you. What else we got? Anything else?
Any other questions for Dr.